Hello doctors, this is Dr. Hira Salman. So welcome to MCQ of the day. This MCQ says diabetic patient on metformin 1 gram twice daily, random blood glucose and A1C still high. What to modify in treatment? So this is very common and this is very important question related to management of hyperglycemia, especially when there is failed monotherapy. So first I just wanted to show you this up to date, and there you can see is management of persistent hyperglycemia and type 2 diabetes mellitus especially. So the approach is, first of all, we have to go for the lifestyle intervention, right? And then we will start metformin. But in particular, those patients who fail initial therapy with lifestyle intervention and metformin are to add a second oral or injectable agent. So as per this, you can see here, WHO guideline that sulfonylureas have a long-term safety profile, are inexpensive and are highly effective, especially when used as described below, with patient education and dose adjustment to minimize side effects. And short-acting sulfonylureas are preferred to reduce the risk of hypoglycemia. So not only this WHO guideline, but also this up to date. And I'll show you the nice guideline also. There you can see we are usually using insulin and sulfonylureas, but there are certain parameters when we are using insulin and especially these sulfonylureas. So monotherapy failure for patients who fail initial oral monotherapy, say for example, like in this case, our patient is on metformin, already on very high dose, and still hyperglycemia is there, HbA1c is raised. There are many available medications that can be used with metformin or in combination. Now, first of all, there are two options we have. One thing is if A1C is more than 9% with symptoms of hyperglycemia, and when there is A1C which is equal and less than 9%. So there are two parameters. One is A1C which is more than 9% and one which is A1C equal to or less than 9%. In our question, unfortunately, we don't have the value of A1C. So let's consider, say for example, if A1C is more than 9%, then we are going to use what? In these circumstances, insulin or GLP receptor agonists are the suggested second-line medications. So either we are using insulin and GLP as a first option after this failed monotherapy. The greater cost of GLP receptor agonists than insulin, especially when NPH is basal, is substantial. And there you can also see the GI side effects and contraindication to GLP receptor agonists as well as cost may limit their widespread use. So because of the side effects of GI and because of the very high cost GLP, we usually don't recommend this. So we all usually opt for insulin. So insulin in case of A1C more than 9%. Just keep this in mind, right? Now coming towards this one where the A1C is less than 9%. In that case, we are using sulfonylureas, our reasonable second agent because they are inexpensive, effective, universally available, and there you can see we usually use this short duration sulfonylureas like glipizide or glimepiride. Most of the time we are using this glimepiride. So two options. One is A1C more than 9%. Keep that in mind that we are using insulin, and we have GLP. I'll just show you this chart as well. There you can have a look that first of all, initial therapy is lifestyle modification. Then we have metformin, and additional therapy. First of all, we have insulin, but keep in mind that insulin you are going to use if it's A1C as per up to date. If A1C is more than 9%, then you're using insulin, right? Because its expected decrease in A1C is 1.5 to 3.5%. So it's very high. Then we are having this sulfonylureas and short acting this glimepiride usually preferable, and it's expected decrease in A1C is 1 to 2. It's rapidly effective. Then we have this GLP, and this you can see glenide is very low, 0.5 to 1.5, and glenide we have repaglenide is more effective in lowering A1C than metiglenide. So glenide we are not, of course we will just keep this as last resort. So we have insulin and we have sulfonylureas. There you can also see this is NICE recommendation, and as per NICE you can see if the person is symptomatically hyperglycemic, consider insulin or in sulfonylureas. Review treatment when blood glucose control has been achieved. So there you have, we are using DPP-4 and pioglitazone, but the most important thing is first insulin and then sulfonylureas. We have combination, dual combination, we have triple combinations. So I'm not just going to go in detail. I just wanted to show you that these two things are very important for us in insulin and sulfonylureas. Now coming back to our question, here we have increased metformin dose. We are already giving the highest amount of dose, so definitely this is the wrong one. Give insulin. So we have two options, insulin and sulfonylureas based on HbA1c value, which we unfortunately we don't have. If we have, so your choice will be very obvious. If it's 9%, more than 9%, go for insulin. If it's less than 9%, go for sulfonylureas. Gliptin and glenide we are not going to use here in this patient, right? Because glenides are the least considered things here, because and gliptin also, this DPP4. So either you are using insulin or sulfonylureas. Sulfonylureas is not there in the option, so I advise you to use this insulin as an option. There I can also show you one thing which is important here. This glenide, you see this glenide is 0.5, and this efficacy is very low, and similarly DP4 is 0.5 to 0.8. So better not to choose, because our main therapy is to reduce the hyperglycemic effect, and then later on we can shift to the medicine.